Good evening, everyone. Welcome to the seventh session of JIPMA's Target Volume Delineation webinar series. Today, we'll be discussing prostate carcinoma, radiology, anatomy, and the target volume delineation of radical and adjuvant prostate. It is a matter of great pride for me to introduce today's speaker, Dr. Thiruvayam Ellamalai. He has done his MBBS in 2011 and is an alumnus of MD Radiation Oncology from JIPMAR in 2016. Sir has cleared his ESMO in 2016 and has been working in the UK since 2018 onwards. He has completed his FRCR and MRCP in 2019 and has been working in the esteemed Christie Institute. Sir has completed his Advanced Radiotherapy Fellowship in the Christie since 2018 to 19 and has been doing a fellowship in Uro-Oncology in Christie from 2019 till date. Sir has attained advanced competency in SABR in prostate. Currently, he is working in the Department of Uro-Oncology in the Christie. So, it is a matter of great pride for JIPMAR to host this session from Dr. Thiruvayam, our alumnus who is working in such an advanced institute. So, sir, I think if you are ready, you can take over.
Yep. Thank you so much for your words, Ninad. It's been a privilege and honor to be back to the same institute where I was trained. I'm really thrilled and excited to share my knowledge and experience in this larger platform. Slight correction, I was working in Christie Hospital 3 months before, and at the moment I'm working as a consultant in Cambridge University Hospital in prostate and breast cancer. Right, prostate cancer. I have been asked to discuss the anatomy and target volume delineation in radical prostate cancer in radical setting as well as in the post-operative settings. So prostate cancer, as you all know, is one of the most common cancer, and with the increase in the incidence of prostate cancer with the aging population and with the increase in the life expectancy, this is likely to be the most common cancer. So what it means to the oncologist like us, we need to know the management of prostate cancer in detail. So I will be touching a base about prostate cancer, its general management. It's going to be a lengthy session for next 1.5 hours. I will try to make this session as much as interactive as possible, giving some real world slides then and there, and then discussing about the updates without deviating much from the target volume delineation, which is my topic. At the end of this presentation, hopefully you all will be able to understand something about the prostate cancer, targeting more on the contouring guidelines. Acknowledgements and disclosures. I would like to acknowledge ESTRO guidelines, RTOG, radiology assistant, RCR. I got permission from the imaging from the RCR who made this slides so that I can extract some of the slides directly. I was trying to include the real world case, but because of the anonymous issue, I couldn't do that. But I will try to I will try to show the eContour website where there is a real case, something where I can show how the contouring has been done without much disturbance. Right. So let's start this prostate cancer by introducing Anthony D'Amico. The reason why I'm starting this to emphasize the importance of radiation oncology in the management of prostate cancer. At the moment, most of the guidelines endorsed the risk stratification introduced by D'Amico way back in 1990s as low, intermediate, and high risk, largely based on the work done by Amico, who is a radiation oncologist at the moment working in Harvard Medical School. So it's just an inspiration as a radiation oncologist or oncologist as such, show that you can make big impact and dominate in the prostate cancer management. And to be honest, it's one of the dream site for any radiation oncologist to work in the prostate cancer management. You got a flavor of working around all the various modalities within the radiation oncology to implement the prostate cancer management right from the beginning till the patients are suffering the end of their life. So it can be placed in the curative intent radiotherapy in low, intermediate, and high risk. It can be used in the post-prostatectomy patients as an adjuvant salvage radiotherapy. After the publication of STAMP-B, high-dose palliative radiotherapy can be utilized in the low-volume metastatic disease. And in recent trend for the past 2 to 3 years, stereotactic radiotherapy has taken over low and intermediate prostate cancer, where you can finish the prostate cancer just in a week time. They call it as ultra hypofractionated radiotherapy. And if you are a stereotactic person and you're fancy about treating the metastatic prostate cancer, there is a likely chance you can treat the lymph glands and oligometastatic in the bone with stereotactic radiotherapy in 2 to 3 fractions. And it's a good site to learn the palliative radiotherapy skills. It's the prostate cancer, if you see the natural course, tends to have a metastasis all along your body, right from the skull base metastasis, spinal cord compression, pelvic bone metastasis, knee joint. So it's a nice site to learn the palliative radiotherapy skills, whether you are treating with a single dose or multiple doses. And for a brachytherapy specialist, again, you can utilize seed brachytherapy in low risk prostate cancer, and you can mix this along with external beam radiotherapy in the high dose brachytherapy. Whatever the modality is coming and going, brachytherapy cannot be easily replaced, as this is the most conformal radiotherapy ever available. And it's a skill to learn to ensure that this is thriving in the competitive world of stereotactic radiotherapy. And there are some recent publications showing that the prostate cancer can be just treated with a single dose of radiotherapy, very high dose, super ultra hypofractionated radiotherapy. We will discuss about that, how this is going to likely to change the trend. And finally, MR-Linac radiotherapy and proton radiotherapy in prostate cancer is not going to help much, but I worked in the MR-Linac setup in Christie Hospital with expensive treatment, but you can play around to have accurate treatment. And there are some randomized control trials going on in the proton therapy, but that's unlikely to change the trend in future. Right. So as an oncologist or as a radiation oncologist, you should know the pathway of the prostate cancer management right from the beginning till how it is presented to the multidisciplinary meeting, so that you can have a full hold of the management of the prostate cancer. So let's start from the screening, how it has been evolving and how it will be referred to you, what's your role, and how likely you can involve in the management of the patients. In the large western part of the world, it's still screen detected cancer, but in our population, from my experience, commonly it is reported patients tend to have their random blood test and they found to have a rising PSA, or sometimes patients presented with increasing lower urinary tract symptoms. Very rarely, let's say less than 5% patients can directly present with cord compression and incidentally found to have a prostate cancer. These are the various ways they can report to our department, and likely to be reported to a general practitioner or surgeons, or sometimes to the urologist, and they will be doing the full examination, concentrating on the colorectal examination, found to have a hard prostate, and referred them to have a biopsy. You can utilize multiparametric MRI if you come to know about the management of the prostate cancer. Recently, there was a publication in NEJM suggesting that multiparametric MRI guided screening, guided biopsy can impact patients' management, can significantly reduce the overtreatment if it is considered. So again, multiparametric MRI means just doing MRI along with some diffusion weighted imaging, which can guide in accurate staging, which can be used as a prognostic, as well as the predictive tool, which can guide either patients are going for surgery or radiotherapy. And we refer the patients to biopsy if there is a suspicious PIRATS 3, 4, or 5 lesion. The biopsy can be either truss biopsy or template guided biopsy. Template guided biopsy are largely replacing these days, where you can get multiple cores. After that, it will be discussed in the multidisciplinary meeting, ideally in the presence of a urologist, oncologist, a radiologist, and pathologist, but it's always better to know about the radiology, pathology before getting into the management, so that you can easily have a full control of the prostate cancer management. TNM staging still have a great impact in the management of prostate cancer, along with the Gleason and PSA value. I will be largely discussing about TNM staging in the subsequent slides whilst we are discussing the anatomy. Just a bit of Gleason score. You might have heard about Gleason 3+4, 4+3, 4+4, and it's again graded, depends upon the score. Gleason 6 means low risk. Gleason 7 means intermediate. It is again divided into favorable and unfavorable intermediate risk. Gleason 8 has been declared as high risk, which is included in the Gleason grade group 4. Gleason 9 and 10 is very high risk, and it is largely a separate entity altogether, with the background of heterogeneous tumor, hypoxia, high propensity for frequent metastasis, and some other variant going on in the background, like neuroendocrine or squamous variant, along with adenocarcinoma. That's separate entity. And there are some recent publications suggesting that Gleason 9 and 10 with low PSA should be considered as a separate, should be treated in a separate modality, separate management wise, as we will be discussing future in further. So to keep it very simple, without it's beyond the scope of this presentation to discuss largely how low risk, intermediate, and high risk will be managed, but I will try to incorporate how radiotherapy is nicely playing around in all these cancers, and I'm just discussing the basic management of low risk, intermediate, and high risk. So depends upon the PSA score and Gleason grade grouping and TNM staging, patients can be branded into low risk, intermediate, and high risk, which has been still endorsed by NCCN, ESMO, NICE guidelines, European Urology. Although there are some changes within this and there are multiple prognostic model coming around, this is still playing an important role in all the upcoming trials. Patients are stratified based on this. So to summarize, low-risk patients can be managed with either surveillance or radiotherapy or surgery. So I will discuss the likely outcome on what's the evidence behind this, but just keep it very simple. Low-risk patients doesn't need any, the low-risk patient doesn't need any androgen deprivation therapy. They just need either surveillance or radiotherapy or surgery. Intermediate risk prostate cancer can be again divided into favorable and unfavorable, depends upon the Gleason grade grouping and the percentage of course involved. But generally, if it is favorable intermediate risk with low PSA, they can be again managed by either surveillance or surgery or radiotherapy. Unfavorable intermediate risk can be treated either with surgery or radiotherapy, along with 6 months of hormone injections when they are going for the radiotherapy treatment. How it would be decided between the surgery and radiotherapy is quite debatable. Ideally, the patient should have a discussion with the consultant urologist as well as the oncologist, and informed decision should be taken in the presence of patients. But what are the symptoms which could aid in deciding between the surgery and radiotherapy? The patients, if they are aged population with multiple comorbidities who are not suitable for surgery, likely to go for radiotherapy. And if they are a younger one, and if they are having high urinary tract symptoms, then they are likely to go for surgery first, rather than, that's the practice I'm seeing, but there are no evidence behind this. It's the patient's decision. High risk patients with Gleason 8, T3B, T3A sometimes included in high risk, but yeah, it's very subjective. I will discuss that again in detail. T3B, Gleason 8 and above, and these are the high risk and PSA greater than 20. Majority of these patients are going for radiotherapy, let's say 70%. The surgery is still an option for this population, but the problem is when these patients are going for surgery, they are likely to be getting the adjuvant radiotherapy as well. So instead of having two modalities, it's fine to continue just with the radiotherapy. Also, the pattern of recurrences in the high-risk population tend to be more distal rather than the local. It could be in the pelvic lymph node region or it could be in the bones. So that can be nicely treated by giving the 2 to 3 years of hormones along with radiotherapy, which might not be possible when they are going for surgery. That's the entire management of low risk, intermediate, and high risk in the intact prostate. We will discuss about the post prostatectomy in future, but just keep it very simple. And if you want to know, if you want to read one paper when you want to discuss, when you want to dominate in the tumor board, I strongly recommend this NEJM publication based on a study of nearly 1 lakh population led by the surgeons. It's a randomized control trial comparing the surveillance versus radiotherapy versus surgery, 3-arm trial, roughly 500 patients in 3 arms in the early and favorable intermediate risk. The conclusion is at the median follow-up of 10 years, there is no change in the prostate cancer specific mortality, regardless of their option, whether they are going for surveillance or radiotherapy or surgery, with the caveat mentioning that the metastasis is slightly higher in those populations who are having active monitoring. There is a caveat here. So if you are dealing with a very young population, you need to discuss the results honestly, saying that there is an increasing trend of future metastasis and progression when they are going for surveillance. But if you are dealing like a 70-year patient whose life expectancy is not more than 5 years, they can pretty well go for the active surveillance. So highly recommend to have just a summary of this study, which will be really helpful in the management. Also, this explains the future trial when they are trying in the low risk and low intermediate risk, when they are trying various options like proton therapy, brachytherapy, seed brachytherapy, ultra hypofractionated single fraction. Regardless of whatever the treatment they are receiving, they are likely to live for next 5 years, 10 years. So we need to really wait for 5 years, 10 years. What is the impact of this treatment on this very early risk? Because even though they are not having any treatment, they are likely to live. And we will discuss about the various surrogative markers for overall survival in the future slides. Just to make it more historical, this is the first publication from American colleagues from California way back in 1965, a preliminary report suggesting prostate cancer can be treated in a radical intent with radiotherapy. And we have evolved so much for the past 50 years, and we have reached this level of treating with advanced radiotherapy in single fractions or 5 fractions. Right, enough background. I think let's move to the proper anatomy. It's already 20 minutes late. So as a radiation oncologist, you need to definitely aware about the anatomy in the way, since you are going to treat the patients based on the anatomy, you should know more than the radiologist, more than any other clinicians, I would say. But you don't need to know every detail, some part, whichever relevant to the management, diagnosis, and discussing the patients. This is an image we have been seeing since our anatomy days way back from medical school. So imagine prostate in the sagittal structure as an inverted pyramid or inverted cone. The base is in the superior level, whereas the apex is in the inferior level. There are various zones which has been divided for discussing the prostate cancer management, but let's concentrate largely on the peripheral zone and the transitional zone. 75% of the cancer tend to occur in the peripheral zone and 20% in the transitional zone. Central zone is not that much relevant to us. What it means to the management of prostate cancer, nothing much, but the transitional zone cancer tend to present in the early stage, as this is nicely encroaching upon the urethra. Patient presents with some symptoms, whereas the peripheral zone tumors are the silent one, which tend to invade and evade the extracapsular extension and may present in a late stage. We in Manchester do quite a lot of lab works to see what it means to understand more about the prostate zones and how this can be placed as a prognostic and predictive, whether it can be incorporated in the staging, like that we are we are doing some lab studies. My role in this is very minimal. It is led by a PhD student who has recently published his work in the Nature review, showing the various zones and what it means in the prostate cancer management. This is a cross-sectional HCl slice in the upper, middle, and the lower zone. Not much useful. So it is very difficult to delineate prostate cancer in the CT scan. That's very difficult. But if you know the anatomy of the MRI prostate, it's likely to help when you are encountering so many cases that can come by experience. You can nicely delineate the prostate, but understand that peripheral zone is crucial. 75% of the cancer can happen in the peripheral zone, and transitional zone is likely to increase in size with the aging population, and the peripheral zone can be thinning around like the crescent of the moon. The neurovascular bundle is the prostate cancer and the peripheral zone tend to invade into the neurovascular bundle, which can impact the erectile dysfunction and other side effects. And it's crucial to include this if there is extracapsular extension or in a high risk case. Anterior fibromuscular stroma is here. So in the TNM staging, T1 cannot be detected. If the tumor is visible in the radiological image, it's already staged as T2. T3A, T3B, if you see properly the guidelines, sometimes they include T2C into the high risk, but that's not the real experience we are seeing. We include T3A and T3B in the high risk, and T3A, T3B is based on the extracapsular extension. You can see a nice rim of hypo intense circle here. Once that's encroached its capsule, I'm showing just T2 tumor, which is, you can see as signal intensity changes in the T2 weighted imaging. That's contoured nicely. Still the capsular structure is maintained, not breached. It's very difficult to stage by a radiation oncologist. It is a very advanced training even for a radiologist. They are still mastering around reporting T3A, T3B. So you can nicely see that the capsule is breached here. That's T3A, and that's T4. You can see that in the coronal section, the cancer is invading into the surrounding structure, involving the levator ani muscles and involving the seminal vesicles as well. So T3B is involving seminal vesicles. T4 is encroaching into the surrounding structures, into the pelvic side wall, bladder, or penile pelvis T3A. So identifying the apex is quite crucial whilst contouring. Just imagine as a coronal structure, this is the urogenital diaphragm, genitourinary diaphragm, and the base of penis is largely located here. So you try to avoid the penile bulb. So you would be contouring something like this. You can see in the coronal structure nicely. It's so good to see in the MRI, but that's not the case in the CT, which I will be showing in future. And better to know the anatomy and urethra just above the penile bulb, how it is coming. At the moment, we are not sparing urethra, and there are no constraints for urethra. But as a part of phase C trial, when we are giving stereotactic radiotherapy, we try to contour the urethra as well. And we are studying whether the giving some constraint to this organ would improve the genitourinary symptoms in future. But at the moment, we try to improve. It's very hard to appreciate in the CT scan. It's all interspersed and obscured by the anatomy. Yeah, that's pretty much the anatomy. You just need to know the TNM staging, how to identify the base, not missing the tumor, location of the cancer, whether it is encroaching into the bladder. If you know about this, you can easily survive the prostate cancer contouring. So just another recent update. If you could recollect, there was a practice changing trial which could change the future management in high-risk prostate cancer, exploring the option of pelvic radiotherapy. If you are really a trial person and you are following the recent update, you should be knowing. Can you guess whether it is a sport trial from Canada or Stampede trial from UK, or Hypo or T from Scandinavian countries, or GETAC from France? or is it pop party from Tata India? If you know the answer, just scroll through. You can just send the message. I will come back to that while discussing the high risk prostate, while discussing pelvic radiotherapy. Okay, moving to the proper target volume delineation. It's all available all over the internet with nice videos, lectures, and you can read through the ESTRO CROP guidelines along with the RTOG guidelines, which is very clear in what is the target volume delineation. Nice video. So I'm just included some of the slides, and I will try to help you understand what it means in the real world when you are sitting and encountering the prostate cancer patients, and what are the difficulties I face and different cases we can go through. And I will go through the original video slides as well. That would be really helpful. So, yep, before contouring, you need to consider certain things which is crucial. It's a routine trend of radiation oncologists not seeing the patient, suddenly seeing the slides and counting, but it is always nice to see the patient and discuss the previous things. What are the checklists you need to do before considering the radiotherapy? First thing is androgen deprivation therapy. So in the intermediate risk, we utilize 6 months of androgen deprivation therapy. It can be LHRH analog, either Prostate, Zoldex, Goserelin, or it can be high dose by calcium 150 milligram. Consider this 6 months for intermediate risk and 2 to 3 years in the high risk. So there is a recent publication, it's a meta-analysis from the American college suggesting that instead of giving neoadjuvant androgen deprivation therapy, better to consider concurrent androgen deprivation therapy, because they come up with this rationality suggesting that radiotherapy there could be addictive effect of radiotherapy along with the androgen deprivation, which some translational potential which can impact progression-free survival, biochemical-free survival without much change on the overall survival. Do we need to change the management based on this? We don't know, but we in our department we always consider neoadjuvant androgen deprivation therapy for 3 months for various reasons. First, for logistic issues, we need some time to plan the radiotherapy, and we have seen in our real experience patients lower urinary tract symptoms nicely controlling with the androgen deprivation therapy, and there are some rationale suggesting we can shrink the cancer, something like that, but I haven't really seen that. And explain the consent, get the consent to the patients, explaining the acute and late side effects of radiotherapy, what it means to them, what are the percentage of side effects that could happen. If they are the younger population, discuss honestly about erectile dysfunction. There is a 50% chance they are likely to be permanent, having permanent erectile dysfunction, and a percentage of long-term GU and GI symptoms. I mean, if anyone knows anatomy can contour, even the radiologist or urologist, but what it means a radiation oncologist is simulate the patient nicely, maintain the good bladder and bowel protocol, and ensure that there is a uniformity followed all along the treatment. There you can make an impact, and nobody is aware about what's going on about this GTV, PTV concept. Only radiation oncologist knows these things. And utilize the multiparametric MRI if possible. Most of the centers are not doing, but this is likely standard to do multiple parametric MRI and see the scan and utilize this. Bone scan in high risk. If the patients are high intermediate risk or high risk, try to do some staging scan, either bone scan or CT scan. And these days they are replacing PSMA PET scan in a high risk group. It has been approved by FDA, and there are randomized control trials suggesting it is more specific and sensitive. So you can utilize PSMA PET, but try to be very prudent in taking the management based on that. Don't undertreat or overtreat based on the PSMA PET scan, because most of the trials so far done has not changed, has not been based on the PSMA PET scan, has not been much validated. So utilize the PSMA PET scan if you're having, but don't change much management. Pacemaker, previous radiotherapy, whether the patient had hip replacement, was just general check. If the patient presents with very bad symptoms, high urinary tract symptoms, refer them for transurethral resection of prostate or add some tamsulosin, which can nicely control the symptoms. That's more important. We have discussed this. Right, coming to the proper contouring session. Quick review of basic, and this is a slide directly taken from RTOG. Apologies, I try to include my own slide and try to draw this nicely, but I can't come somewhere close to what they have done. So better for teaching, try to use their slides, and it is openly available. Shouldn't be a problem, I think. So this is just a sagittal structure. You are already doing quite a lot of counting in the pelvic structure. There shouldn't be a problem in identifying the bladder, prostate, rectum, seminal vesicle, pubic symphysis, pineal bulb. If you know the anatomy of these structures, that's enough. This is the easiest contouring across the sites of radiotherapy. To be honest, you can finish the prostate contouring within 5 minutes. When I just sit for the contouring, already rectum and bladder could have been contoured by the dosimetrist. My job is just to identify the prostate and the seminal vesicle and giving the CTV and PTV. That would be again done by the physicist. So it's easy structure to work with. Pubic symphysis will be coming and guiding you then and there in the anatomy, in deciding the apex and everything. So pretty much aware about identifying the pubic symphysis in the sagittal plane, which is and in the mid plane of the sagittal. If you scroll through the anterior and posterior sagittal, this is likely to change in structure. Just keep it in the center of the sagittal slice. You can nicely see the middle part of the pubic symphysis, which can guide you easily in picking up the apex of the prostate. And the same on the axial and coronal. It's looking so nice if it is already contoured, but just my history, when I was sitting for the FRCR exam, they randomly asked me to find the bladder, prostate, and although it seems to be easy, when you are in the exam stress, when you need to contour in a single slice, you will be confused which is bladder, which is prostate and rectum, and this is the most common mistake most of the students did. But it's easy. If you scroll through some slides above and below, you can easily pick up bladder, prostate, and rectum. Obturator or internus muscle, just aware about identifying this. This will be guiding you in some other, when we are discussing about the salvage radiotherapy. Rectum is quite easy. So start with the OAR contouring, start with rectum. You can nicely see the sling of levator ani muscle around the rectum. If you can identify this, leave it, or else just contour the rectum all around. Superiorly, as usual, when the rectum is turning into sigmoid colon, stop it. Inferiorly, find the ischial tuberosity, and when it reaches the inferior level, stop the rectum. The contouring of rectum should be uniform within your hospital so that you can use the constraint nicely, because it is not based on the CC volume. This is based on the percentage relative volume. So how much ever you are contouring the rectum actually impact the constraint. So try to be uniform and accurate in contouring the rectum in the superior and inferior level. And you can play around the window. If you change from the pelvic region to head, you can see the posterior margin of the prostate and the rectum. It's all looking same, but you can nicely see something here. The anterior limit of the rectum. I will show you in the subsequent slides. Yeah, you don't need to control all the slides. Just do it here, and do the interpolation. It should be available in all the softwares, Eclipse or Monaco or RayStation. Next, pineal bulb. Pineal bulb is not difficult. You can identify the penis nicely in the sagittal and try to contour the base of the penis. In the axial section, you can nicely see the small black color region here, which is a fat space, which can help you in drawing the pineal bulb. The reason why we are finding pineal bulb is that can help you in drawing the lower limit apex of the prostate, and it is based on the evidence by Lee et al., who has studied nice contours of so many patients and suggested normal anatomy. Apex most of the time ends 1 centimeter above the pineal bulb or 0.5 centimeter above the pubic symphysis. So if you can pick up the pubic symphysis, just draw a line. It should be about 0.5, or draw a pineal bulb. It should be 1 centimeter above. there is a large variation. If you ask 10 radiation oncologists, everyone will draw differently. But what's more important is read the MRI. If the cancer is located in the apex, try to be a bit generous. Try not to treat the pineal bulb. That's it with the bladder, prostate, bladder and rectum. Coming to the prostate, it's quite easy. Find it in the middle and draw this nicely. You don't need to include the levator ani muscle again. It's quite difficult to find in the, this is actually looking good, but in the original case, it's very difficult. So we tend to draw something like this. But if you know how much tissue to spare here, you can see the width of the levator ani muscle here. It is likely to be the same or lesser than this. But it won't make much difference because these are all relatively radio-resistant structure. Even if you're trying to be generous, it's not going to make much impact. The volume will be slightly increased. You need to be extra cautious if you're considering stereotactic radiotherapy. You need to utilize MRI or fiducial, something like that. Careful about involving the posterior margin of prostate. Yeah, start from the middle, drawing the contour, and you can reach the apex and base as discussed previously. Yeah, as it is going to the apex, it will be tapering down something like this. This is a slide comparing how it looks like in the original MRI and what it is simulated if it is in the CT. You don't need to include the anti-retropubic space, which contains some venous plexus or vessels. You can include the fibromuscular stroma, shouldn't be a problem. But if you are confident enough, you can make accurate delineation. Sometimes they tend to spare urethra, which is located anteriorly in the apex region, but that's very difficult in the CT, as you can see here. But it will be like a butterfly shape if you properly contour. Don't go more anteriorly in the apex trying to spare the posterior. So always prostate apex is just above the rectum, like a butterfly shape here. And involving the base of the, contouring the base of the prostate is slightly tricky again. Most of the time it is quite visible. If you are using the contrast, you can nicely see if the prostate is encroaching into the bladder. Sometimes median lobe can go into the bladder. But if you are not utilizing this, again, change the windows of the your planning station and see. You can see a differentiation between the urine and the prostate volume and include that. How much seminal vesicle do you need to include in the high risk volume, intermediate risk volume, low risk volume is still debatable. I will discuss. I keep it very simple. In the low risk patients, you don't need to treat the seminal vesicle at all, because even if they are going for surveillance, they are likely to live. So you don't need to treat seminal vesicle. If it is intermediate risk, include 3 to 4 slices, let's say 1 to 1.5 centimeter of seminal vesicle. If it is high risk, include 2 centimeter seminal vesicle. Depends upon your contouring slices. If it's 3 millimeter slice, include six slices of contour of seminal vesicle. And when you are contouring, always think about how much dose the prostate is going to receive, how much dose the seminal vesicle is going to receive, what is the constraint for rectum. That's more important. As a general, we use hypofractionated radiotherapy. So we give 60 gray to the prostate and 48 gray to the seminal vesicle, but the practice varies across the world. People still doing the conventional fractionation, and you can treat somewhere around 74 to 78 gray the whole prostate, and you don't need to treat the full dose to the seminal vesicle unless it is involved. You can treat them either with 85% of the dose, giving like 60 or 64 gray, respecting the constraints. So we give 48 gray in 20 fractions to the seminal vesicle. Yeah, these are all the various trials showing how seminal vesicles are contoured or involved in those trials. Just see around and play around. If the seminal vesicles are really involved in T3P case, include the seminal vesicle into the prostate, into the high dose region, because seminal vesicle is not going to receive the radical dose. It is going to receive only 80% or 85%. And if it is again very high risk, try to include the initial part of semivesicle, at least 1 or 2 slices along with the base into the high risk volume. That there is no right or wrong answer involving the semivesicle, how much ever included into high risk or intermediate risk, but play around, follow your trust guidelines or your hospital guidelines policy. That's it with the semivesicle. And you can see in the sagittal, and you can measure around how much seminal vesicle is involved. This is an intermediate risk, so they have included 1 centimeter. If it is high risk, you can slightly go a little bit higher, and it also depends upon patient's anatomy. Some patients tend to have a chunky seminal vesicle, and that's keep on going till this level. But understand that if you include more seminal vesicle, you will be giving a margin around of 1 centimeter, and that's likely to include the large part of the rectum, which can give you trouble when you are doing the OAR analysis, can cross the constraint. Then you need to sacrifice either the OAR or the seminal vesicle, and then you should cut down here. So just see the risk factors and discuss the side effects with the patient and play around. Yeah, this is again an MRI series of MRIs showing how the contours are looking in the MRI. If you keep looking into the MRI frequently, you will be understanding how this is going to be in the CT scan. Again, in our hospital, we do quite a lot of artificial intelligence stuff. I was involved in doing this analysis as well. So it's led by physicists. We try to see what is the pattern of recurrence in the prostate cancer patients who are receiving radiotherapy. We included nearly 1,000 patients, and we were trying to import all the contours together, and we were trying to see what is when we were divided the patients who are having recurrence and not having recurrence, and we were trying to see the coverage in the seminal vesicle area and in the retropubic space area. So what we found in the seminal vesicle area and in the retropubic area, there are some underdose coverage, which might be the reason for the recurrences. We don't know yet. This is really hypothesis generating. We need to see the follow-up of these patients, and we should have done the CT scan or the MRI scan to see whether is this the real reason for the recurrence. But we just try to do some analysis to understand the pattern of recurrence and pattern of coverage in these patients. Yeah, data mining work. So after contouring, what's our role as a residents or as a trainee? We just contour the patients and we don't follow up. Most of them will be followed up by the consultants or the physicists, which again I have realized after becoming a consultant, we need to be involved heavily even after the contouring. So prostate contouring is quite simple. You can follow 3 dose level CYP protocol, or you can follow 2 dose level. This is the Christie protocol based on the CHIP trial. But when I moved to Cambridge, we follow just 2 dose protocol. Prostate only, prostate plus seminal vesicle. This will receive full dose. This will receive 85% of the dose. And PTV, need to be a bit strict with the PTV when you are going to devise a protocol in a small center. Just be ensured that the margin in the posterior region is very strict, because the prostate gland is going to receive 74 gray equidito, which is very huge dose for the rectum. So ensure that you are not giving much margin, at least in the very high dose region, 74 gray. If you are including PTV, you can give a margin and you can give 90% of the dose, but we are not doing the PTV. We directly jump to PTV1 and we give 85% of the dose. This is a bit generous. So this is confusing, and it took nearly 6 months for me to even understand what is with this CYP. Don't worry about, sit with your colleagues, with your seniors, and devise a protocol of your hospital. PTV is really not a universal concept. It is a hospital concept, and it is a cultural concept. If you are doing cone beam CT on a day-to-day basis, and if you're confident enough doing the fiducials or CyberKnife, you are pretty much safe. But if you're not doing that, you just need to be careful, as prostate is likely to change in the anatomy during the treatment because of the rectum and the bladder. Constraints, again, constraints widely vary, depends upon the fractionation, depends upon the center, but it's all, if you go back to basics, it's all based on the Imami or the routine standard, whatever we have read, and they have slightly adapted according to the equity to calculation. So just see and work around. After finishing the treatment, you may be randomly called by the radiation technicians to radiographers to see, could you please check whether if this is properly aligning. So it's nice to see that how they are matching on a day-to-day basis and what are the changes you would be doing. If the rectum is enlarged significantly, then the prostate can be pushed further and the isodose volumes can fall into the rectal region. And although the constraints are looking nice in the paper, it's not the case the patients are receiving. So ensure the uniform maintaining of rectal structure across the treatment. Follow the bowel protocol, ask them to empty the rectum, use the laxatives or whatever your hospital is using, maintain the structure uniformity. Same thing with bowel. Change in bowel can significantly change the coverage and volume. And this is one nice slide showing that how the rectum is changing in size, more dilated rectum, more connection with the posterior margin of prostate, and how this could significantly impact the entire change and the dose calculation. Right. As a summary, in an intact prostate or in the radical setting, start with contouring rectum, finish the penile bulb. Ensure apex space adequately covered. Try to avoid levator ana if at all possible. See the original MRI scan, and if the extra capsule extension involved, just to give a generous margin, let's say 3 mm margin around the structure. And better to know about the transitional and peripheral zone anatomy to include the fibromuscular stroma in transitional tumors. 1 to 2 centimeter seminal vesicle in intermediate, 2 centimeter in high risk. Follow ICRO guidelines, ICRA guidelines, and the trust protocol for plan evaluation. A bit of history before moving to the next contouring session. The number of people getting Nobel Prize in our field is relatively less, only a handful of people, let's say less than 10. Surprisingly, this gentleman received Nobel Prize in 1960s, I think something, yeah, 1966. He pioneered the discovery of hormone management. The prostate cancer can be controlled with the hormone treatment. And inspired by his work, the hormone treatment coming nicely controlling the breast cancer as well. And to be honest, 30% of the metastatic patients can be controlled just by hormone injection, thanks to Charles Higgins and his work. We have evolved so much after this discovery. First case was reported in London in 1853, and then the castration concept came in 1941. And recently, 10 years before when I started my training, abiraterone was accepted, and it is coming out of patent. And abiraterone is there everywhere now, even in high risk, which I will discuss in future in subsequent slides. Stereotactic radiotherapy in the radical prostate. The people are largely using stereotactic radiotherapy these days, but I would be a bit cautious in waiting for the future results. Recently in the ISTO 2021, they updated the 2-year follow-up of phase C trial, which treated the prostate cancer in 5 fractions. They suggested that there is a slight increase in long-term toxicity compared to the standard fractionation. And they attributed that the centers who are having CyberKnife are doing relatively well, which might not be possible in all the centers. So we need to be cautious when you are using stereotactic radiotherapy, particularly the side effects of the patients, because as I said already, the biochemical recurrence or overall survival is not going to change much in the low risk or low intermediate risk. So be cautious with the side effects. Right, let's take a break for just 2 minutes before starting the salvage setting. The salvage radiotherapy is not very big. It's just I can finish this in 10 minutes time, and then we will discuss about the pelvic radiotherapy. Then we will discuss about the future and current trends going on in the prostate cancer treatment. You can stretch your legs for next 2 to 3 minutes time, and you can share some questions in the chat box, which I can read in the meanwhile. and I can try to formulate my answers. I will come back in 2 minutes.
You can post your doubts in the chat box. We'll compile the doubts and in the end we'll have a Q&A session cumulatively.
Okay, let's start with the role of radiotherapy in the adjuvant settings after surgery. What is the evidence available and how we are countering the post-operative case. So the definition of biochemical recurrence as devised by the prostate cancer working group, it's quite different in the post-operative post-prostatectomy as well as post-radiotherapy. We are all familiar with the Phoenix criteria. After radical radiotherapy, there should be a PSA rise of 2 nanogram per liter or more above the nadir. If they reach like 0.5, it should be 2.5 at some point. And this is not likely to happen in the real world. So if the patients are receiving 2 to 3 years of hormones, naturally their PSA will be suppressed. After 3 years, you can start seeing the PSA rise in the very high risk population. Whilst in the post-prostatectomy sample, ideally the PSA should go back to 0 or 0.01 or pretty undetectable. But if it is rising, it's a bit alarming and the patients are quite anxious. They will be asking what it means if the PSA is rising further, where this is coming from. And that there is a quite a lot of debate going on. Should we need to consider the immediate treatment or should we need to wait for some time to see where this is coming from? So when they are removing the prostate, they can't remove the whole prostate. Although they are trying to remove the whole prostate, there are always some tissue pending behind, which can cause the PSA rise, or there might be relapse going on, which can cause the PSA rise. So in the pathway, after the PSA is rising, check the PSA in 6 weeks' time. The PSA assay available these days are quite sensitive, and if it is crossing 0.20, then you need to be a bit cautious. And there are quite a lot of trials available suggesting that it's the right time to intervene once it crosses 0.20. You don't need to consider immediate radiotherapy. You can consider salvage radiotherapy. What is immediate radiotherapy? So there are certain high risk features like in head and neck cancer or cervical cancer. If there are positive margins, if there are very high risk, if the PSA baseline is very high, you can directly consider adjuvant radiotherapy. But that's not the case in prostate cancer because it's a slow growing cancer. You should not overtreat the patients. You should not give extra side effects. They already had a prostatectomy. It should not further complicate by giving extra radiation. And more importantly, it's not syncing with the latest available evidence. So to answer this question, there were 3 meta-analyses, well-conducted meta-analysis, radicals, raves, and GETEC. And there is a meta-analysis based on these trials. They come to a conclusion, you don't need to consider immediate radiotherapy. You can wait for the PSA to get back to 0.2, and you can consider salvage radiotherapy at that point. And these 3 trials included all the risk factors you in the tumor board would be claiming to consider radiotherapy, the positive margins, seminal involvement, very high risk, all included in a large proportion in these trials. What are the things you need to consider before salvage radiotherapy? So try to do the traditional scans, MRI or bone scan, to ensure that this is not metastatic, this is local recurrence. PSMA PET can be definitely utilized in this setting, and there are some latest evidence from Empire trial suggesting it can actually help the radiation oncologist. It can dictate the management. So try to use the PSMA PET scan if it is available. Discuss about androgen deprivation therapy. So if the patient never received androgen deprivation therapy, which is likely the case in the surgical cohort, you can discuss 6 months of androgen deprivation therapy. Whole pelvic radiotherapy is debatable here, but there is a latest publication, presentation in the ASTRO suggesting that this is likely to change. I will discuss the crux of that meeting. Try to analyze the full post-op histopathology and discuss the side effects and check the IPSS score and intervene before radiotherapy. SPORT trial, which is largely from Canada, I think. They were trying to see in this setting whether we can consider whole pelvic radiotherapy along with androgen deprivation therapy. And it's a positive study suggesting that there is a robust evidence suggesting that by considering whole pelvic radiotherapy, it can significantly reduce the distal metastasis and it can be translated into overall survival. It is not published yet. It has been presented and already cited more than 100 times, just the abstract, but we need to wait for this results before jumping into considering whole pelvic radiotherapy. But that's likely to be the future, I think. Coming to the guidelines for the contouring, it's pretty much similar in the radical prostate. There is a slight variation in the contouring. You can refer to either RPOG guidelines or radical guidelines, pretty much similar, mild moderations, and I will discuss where are the variations. Generally, you need to be a little bit generous, a little bit, you need to include extra slice in the superior and the inferior level. And imagine they have removed the prostate and you are just covering the fossa region, and you try to recreate that how the prostate is going to be there if there is a prostate. And again, start in the sagittal structure, go to the middle of the nice sagittal structure and use the pubic symphysis as the guidance in contouring. After finishing the rectal contouring, bladder contouring, penile bulb contouring, this is the fossa you are trying to treat. You can see the vesicoureteric anastomosis at this part, which is the likely area of recurrence. So invariably, you have to include the bladder. You can't avoid the bladder, at least below the pubic symphysis. Above the pubic symphysis, you don't need to include the full bladder. I will discuss the difference in contouring guidelines between that. But below the pubic symphysis, try to include the whole bladder. And I will discuss how much superior and inferior you will be covering. So you are starting in the inferior region. As I said, include whatever the structure below the bone and include the levator and muscle, because this is the post-op setting. You don't want to give recurrence again. Try to be extra generous. You are not going to spare anything here. And try to include the neurovascular bundle as well if possible. Rectum will be properly impaired, touching down in the prostate. Just crawl through the obturator internus muscle. Same thing, you are including the structure just behind the pubic bone. Same thing. Yeah, they have included nicely the levator muscles. Once you have started coming above the pubic bone, you can start coming out. You don't need to include the whole bladder. You can slowly come. You can see that the pubic symphysis is just slightly coming away. So you can move the anterior margin of the contouring slightly posteriorly. You don't need to include the full thing. And further above, you don't need to include, just include posterior two-third of, here it is very tight. You can include posterior two-third of the bladder. So this is the classic slide. You can see that tumble shape here, including the previous seminal vesicle region. If there are some clips which could guide you in, try to include the clips and try to include the perirectal tissues. So don't draw flat like this. Try to encroach here, and it should be like a concave or convex shape. In the lateral aspect, try to come till the obturator internus muscle. You don't need to go into the obturator internus muscle. Yeah, include the clips wherever possible. Wax different. You don't need to go further above, including the whole part of the seminal vesicle if at all possible. Superior part, it's quite varied. You can include 3 centimeter above the pubic symphysis, or you can see if there is any visible seminal vesicle remnants, you can include that. Again, it largely varies. Just see that where the superior part of the pubic symphysis coming, include 3 centimeter or 4 centimeters above that. In the inferior margin, again, penile valve will be helping you guiding, but don't give 1 centimeter margin in the penile valve. If you can possible, identify the vesico-urethral anastomosis, which is very hard to find, but it is just above the penile valve. Give a 0.5 centimeter margin above the penile valve, but it's slightly bit generous and extra volume than the intact prostate. And always check in the sagittal structure. It should look like something coming in below the pubic symphysis. You will include the whole bladder, and above the pubic symphysis, you will just include the posterior two-third of bladder. That's it, easy. Again, you can finish in 10 minutes time. And check in the coronal structure. You are including the fat spaces here and here, which are the likely area of metastasis. Dose 52.5 grain 20 fractions is that what we are using. You can use 66 grain 30 fractions. It's permitted in the radical trial, and you can refer to the original trial and the constraints, whatever they have used. I think there are no constraints for bladder here since we are irradiating the bladder, but there will be a constraint for rectal. This is what we are using. Check your protocol. As a summary, follow the radicals protocol, well-established one. Try to be a bit generous around the prostate. Inferiorly go up to penile valve. You can just spare 0.5 centimeter of penile valve, thinking about the PTV. And superior margin should include the seminal vesicle remnants, include the surgical clips anastomotic side. Remember about the inverted hourglass appearance. It should be looking something like that. That's finishing the post-operative setting. Let's move to the high-risk prostate cancer. What are the changes happened, and then we will discuss slowly about the whole pelvic radiotherapy. So out of the whole prostate cancer, whatever we have discussed, low risk, intermediate risk is just 50%. Remaining 50% high risk and metastatic patients. The outcome of the high risk and metastatic is still poor. 60 to 70% patients only of high risk can get complete biochemical recurrence. Remaining 30 to 40% definitely will be progressing at some point of the time. And these are all heterogeneous group. It's not, when it reaches more high risk, it is not just hormone driven cancer. There are some hypoxia element going on, genetic mutations, BRCA, PTEN, or the various studies going on, and there are some immunotherapy evaluation going on. So there are plenty of things going on in the high risk prostate cancer, and better to know the pattern of recurrence, whether they are coming back distally in the para-aortic region or in the pelvic region, which will definitely help you in guiding the management. PSMA PET scan can be utilized in the high risk prostate cancer, as I already mentioned. As we are discussing now, there was a publication just 2 days or 3 days ago in Stampede, updated its high risk. Stampede generally is a multi-arm, multi-stage randomized control trial, which included nearly 10,000 patients, and it's trying to answer most unanswered questions in the prostate cancer. And no other trial in any other site has influenced as good as Stampede, which has largely dictated so many practice-changing trials. just a week before they come up with this practice-changing trial, abiraterone can be utilized in the high-risk prostate cancer patient, but this should be very high risk. It can be node positive or the PSA should be very high. You can use 2 years of abiraterone in these patients along with radiotherapy. This is not a published, and once this is published, it's likely to change the landscape of high-risk prostate cancer. And I will discuss the POP-RT. Coming back to the answer, this is from the TATA trial by Vedamurthy and his colleagues who have nicely updated the practice-changing trial of treating the high-risk prostate cancer patients with whole pelvic radiotherapy. And it is already changing the practice in most of the centers. I presented this POP-RT in the journal club in my Christie Hospital, in the likes of Peter Hoskin and other people. That there were some criticisms in the trial, but that's largely this is going to change the practice. But we need to wait for the pivotal BOOST trial, which is something similar we are doing in the UK, comparing the prostate versus prostate on pelvic radiotherapy, huge population multicenter trial. Again, stereotactic radiotherapy is explored in the high-risk prostate cancer, favorable high-risk prostate within the phase C trial. POP-RT, in the high-risk prostate cancer patients, after doing PSMA PET scan, if it is negative for the pelvic metastasis or any other metastasis, whether we can include the whole pelvic radiotherapy is the rationality. And you can see there is a biochemical free survival benefit and disease-free survival benefit and distal metastasis-free survival benefit. So metastasis-free survival benefit is the latest surrogate marker for the overall survival. In head and neck cancer, the local recurrence is a surrogate marker. When the patient is locally recurring, that's likely to progress. That's not the case in prostate cancer. The patient can have biochemical recurrence. The biochemical recurrence starting already in the 4th month, but they are all living nicely till 8 years, 7 years, something like that. So it's not the surrogate endpoint in the prostate cancer. Whereas metastatic free survival has been accepted as the surrogate marker. But in this study, how you are doing the metastasis free survival is a point. Again, if you are doing by conventional imaging, that's fine. But if it is by the PSMA PET scan, if you are evaluating the distal metastasis, then that's not validated. It is likely to overpick the disease. And again, it can show that there is a distal metastasis free survival, but not reflecting on the overall survival. So we need to wait for the overall survival to mature before changing the practice. And it is a single center study, and it's a small study. The events are very, very less, like 8 events, 4 events. If the events likely to change in next few months, the statistical significance at the moment showing could likely to change. So there are some caveats within the study, but anyway, appreciable, published in JCO from India, practice changing. And the another thing is they have done similar trial before. Both are negative trials. That's another reason we need to change. We should not change the practice straight away after seeing the POP-RT. But there are some pitfalls in this study. They haven't utilized ADT fully, and they haven't covered the nodal fully. Those are the arguments by the author. But again, we don't know whether the impact is because of the ADT 2 years they are giving. And the overall survival is very good in this population, like 90%, which raises the questions of the validity of the PSMA PET scan. In this largely high-risk population, PSMA PET is not picking anything, questions the validation, specificity, and sensitivity of the PSMA PET scan high-risk population. Right, yeah, this is Stampede, new standard of care in hormone sensitive. So regardless, you will be asked to contour nodal radiotherapy in a single node positive prostate cancer patients or in the very high risk prostate. Last week, I saw a patient who knows already about a lot of trials. He said that I want this pelvic radiotherapy. Don't put me in the pivotal trial. There is a randomization 50%. I might not get. So it's sometimes patient choice. Say that, yeah, I am going to get this. And he is, to be honest, he's very high risk, Gleason iron, T3B disease. So it's okay to consider pelvic radiotherapy, which is going to be the future. So This is prophylactic pelvic radiotherapy. That's the concept you need to understand. And we are not going to consider full dose to this region. We are going to treat the full dose here, 70 gray or 60 gray in 20 fractions. The dose fractionation to the whole pelvic is really a big thing. So you can consider, in our department, we are doing 44 gray in 20 fraction. And if you convert to equi-D2, it will be somewhere around 45 to 50 gray. So try to play around what is the constraints you can use in your department for the bowel. And if as long as you are treating with 45 to 50 gray, that should be sufficient as a prophylactic dose. If there is a single node positive and it is hot and it is not responding to antigen deprivation therapy, you can escalate the dose as much as possible, respecting the constraints. We will discuss that in later. So what is the guidelines for the nodal contouring? There is a recent publication in Red Journal where all the leading radiation oncologists across the board are asked to do the contours. We follow pivotal boost guidelines, which is slightly little bit generous compared to RTOG guidelines. We follow the L5 S1 upper border and in the inferior border 1 centimeter above the pubic symphysis. Whereas in the original pop party, they have replaced L4 L5 junction. And some people use L5 S1 junction. We use L5 S1 because we don't want to give extra toxicity and they are node negative, and this is prophylactic dose. In the publication in Red Journal, they found that there are quite a lot of contour variation in the superior aspect, in the inferior aspect, in the presacral region, in the inguinal region, and in the posterior region. So we will discuss one by one quickly, not going into elaborate on us. It is still debatable to consider pelvic radiotherapy in prostate, but I will try to. It's something similar like what we are doing for the cervical cancer patients. Nicely include the vessel, artery, and vein, and try to give 7 millimeter margin all around. The superior aspect, as I said, start from L5S1 or L4, L5, whichever you are comfortable with, but try to respect the constraint. You can be a bit generous. Try to cut down the muscle, cut down the bowels, cut down the bone. Just follow through the artery and the vein. And use the roller ball. You can use 12 millimeter roller ball for the presacral nodes. You don't need to go into the foramina or something like this. You can stop at the S3 level. In this, they have included from L4, L5 superiorly, and presacral included till S3 level. You can see here the interspace between the external iliac and internal iliac can be connected by 18 millimeter roller ball, or depends upon the anatomy really. If the patients are very bulky, you just need to include the small tiny vessel and looking like this U-shaped structure. You don't need to draw the vessel and give a margin 7 millimeter. You can just draw directly like this, unless you are doing within the trial. In the pivotal boost trial, we need to respect so many things. We have to contour the vessel, we have to contour the bowel, cut down from 3 millimeter. So you just don't need to follow unless within the trial. In the inferior part, you can stop the external iliac once you start seeing the femoral neck. And in the posterior border, as long as the inferior gluteal artery is visible, you can contour that. But once the seminal vesicles start reaching, you don't need to come below and include the arterial vessel here. And in the most inferior part, just use the roller ball, 18 millimeter roller ball, and include like structure something like this. And 1 centimeter, you can see the obturator internus muscle here. Include the posterior margin of obturator internus, just 1 centimeter above the obturator internus. Follow the same thing. Where you would be stopping is again debatable. If you see the pubic symphysis start coming around, stop with that. You don't need to come further. Or some people will follow the seminal vesicle where it is attaching the prostate and stop with that. So either way, it's again not standardized yet. Follow whatever you are comfortable with, and create a uniform practice so that you can study the side effects really well. Yep, that's it with the nodal contouring in whole pelvic radiotherapy. And with this, I'm finishing my session. if you have any questions, I'm more than happy to take my questions next few minutes. Right, I got a question from Sutanaka Chakraborty. How much margin do we give to GTV for CTV to prostate? So in prostate, there is no GTV concept actually. This is under the investigation whether we can contour the GTV and we can give dose escalation within the GTV, but that's as a part of pivotal boost trial we are doing. Generally, there is no GTV or CTV in prostate. The entire gland is treated as CTV. That's it. And the PTV margin is your department protocol, whether you are giving 7 millimeter, 1 centimeter. But as I said, try to be very tight in the posterior margin in the 74 gray volume. Otherwise, there is no GTV, CTV concept in prostate cancer. A CA prostate patient with lower para-aortic node involvement considered as M1A disease should receive prostate only RT or larger volume. Right. So that's a debatable question. To answer this question, you can see the stampede. Within the stampede high risk population, there are 200 or 150 patients which they included node positive patients, including the para-aortic node. And the publication suggested that prostate radiotherapy definitely should be considered in this patient. And those patients, do they need to receive whole pelvis? Definitely not. If it is pelvic nodes, I will definitely consider. But if it is para-aortic node, this is more like a systemic disease. You need to utilize abiraterone, docetaxel, or the novel anti-androgens along the lifelong androgen deprivation therapy in this patients. So this is more like a systemic disease. Radiotherapy definitely to prostate, whole pelvic radiotherapy, not for para-aortic. If it is single node positive pelvic node, you can consider, but that's again not standard yet. And this cannot be proven in further evidence. We collected a retrospective data within UK, nearly 400 to 500 patients. What is the pattern of practice in node positive and what is the pattern of practice? So these patients are largely treated with just hormone deprivation therapy along with prostate radiotherapy. Some people consider whole pelvic radiotherapy, but the analysis suggested no benefit in considering pelvic radiotherapy. I am presenting this in next GU ASCO, and we will publish this soon. But that's retrospective data, and there are so many limitations within the retrospective. So you can take evidence from stampede data once this is published. And anti-androgen therapy regimens commonly followed. Okay. So commonly, you can use LHRH analog or LHRH antagonist. This is if you are using 6 months of androgen deprivation therapy, I will use 3 monthly Zoladex injection, which is 10.8 milligram, I think, every 3 months time. I always start with bicalutamide 50 milligram just to reduce the flare-up of events, and the bicalutamide will be stopped after 1 month time. Some patients who really don't want any injection, you can consider bicalutamide 150 milligram, which is the standard dose, standalone dose for 6 months time. If you are using for 2 to 3 years time, there are quite a lot of newer agents coming around. Decapeptidyl can be used once in 6 months time. Zoladex, Prostate, yeah, those are the things you can use. Degarelix can be used if you want to have a very good response, very quick response in cord compression, something like that. But I think that's available monthly dose. I'm not sure about the dose. Can you please tell us about the bladder protocol used in your center and regarding the administration of bladder contrast? Bladder contrast really not required, which can complicate the situation and can overwhelm your radiographers. In our center, they say that comfortably filled bladder, which is a broad terminology. Nobody knows what is comfortably filled. You can ask them to have a 200 ml or 300 ml, or you can ask them to drink full bottle and drain it just before some time fully and take 300 ml water before that. To be honest, I don't know what my trust is following. I will go and look back what they are using, but my memory is like they are using 200 ml or 300 ml. Sagar. Thank you, sir. Very nice deliberation. Ninad, whether bladder protocol compliance is good despite acute cystitis during 70 gray plus equally-2 of the RT course. Yeah, that's one of the reason we are leaning more towards the hypofractionated and saber radiotherapy, because you can't maintain the same bladder protocol across 30 days treatment. But when you are using just 5 days or 20 days, you can nicely control the patients. You can maintain the bladder protocol, and you can control the you will have some control when you're using hypofractionation. And the world has changed towards hypofractionation. Previously, they were using the standard fractionation because it's based on the fractionation based payment, but now it's not the case. It's the overall treatment. If you treat prostate cancer patients, you will pay a similar amount. So you don't need to you need to ask the patients to pay for the fractions. And if you see the bladder, if you see in the bladder cancer, hypofractionated RT is slightly better than the conventional fractionation. That there may be some publication coming in the prostate as well. When do you consider for ADT in salvage setting? So long-term, short-term? That's a good question. So there is no benefit of long-term ADT in the salvage setting. You can consider only 6 months time. Again, we can quote from the sport trial where they have replaced 6 months of androgen deprivation therapy, and there is very good control rate, and there is an increase in the metastatic free survival. So we use 6 month androgen deprivation therapy. If you're following Twitter, there was a huge debate whether should we need to consider 6 months or 2 years, something like that. If the PSA is 0.2, 0.3, 0.45, that's fine. It's just local recurrence. But if the PSA crosses 0.89, there is a metastatic element going on. So you can take decision if you want to have a long-term or short-term based on that, but we are following 6 months short-term. Thank you so much. Sir, do you prefer SIB or sequential RT for nodal boost for cross nodes? We follow SIB. It's quite easy, and you know the constraints of the structures in one go, and there won't be any replanning or based on that. So the world is moving more towards SIB in all the sites, so we recommend SIB. Nicely delivered prostate RT. When do you consider for 36 gray in 6 weekly fraction in low burden metastatic disease in Stampede? Right. So in the low burden metastatic disease, the real benefit is actually with 55 gray in 20 fractions. But some of the patients who are really elderly, as I saw last week, like 75-year, 80-year population, where it would be too much to consider 20 fraction within a stretch. So in those patients, we try to explain that he might not get the real overall survival benefit, but still it is equally good, and we tend to use 6 fractionation, and it is very compliant for the patient. They're really happy, and they have a nice time in 1 week to recover from the each side effects, the tiredness and the more urinary symptoms. So yeah, 3666 is very popular in our hospital. Sir, what is your preferred positioning and immobilization device for management of pelvic radiotherapy? Nothing much. We use backlog, no ORFIT or anything like that. Whatever we use for the cervical cancer or endometrial patients, same thing. As long as you are maintaining the bladder and bowel protocol, you should be confident enough in maintaining the uniformity along the treatment. If you're using the prostate radiotherapy, you can use fiducials. We are quite frequently using fiducial. Just putting a gold seeds, very easy procedure. And it can ensure that the constraints are nicely maintaining and the prostate is receiving the proper dose. Thank you for your comprehensive. For ultra hypofractionated, do you prefer to avoid urethra or including TVD? In the low and intermediate population, we don't contour urethra, whereas in the unfavorable intermediate and low high risk population, we contour urethra, but we don't have any constraints, to be honest. We just follow the urethra. In Christie Hospital, we use MRI based contouring. So our urethra is quite visible nicely, and we seek the help of radiologist as well if it is at all required. No constraint to the urethra. We just see the volume and we are still studying. Unlikely to change in future as well, because urethra is very opposed to the apex, very unlikely to spare this. Low volume metastatic disease, prostate only or disseminated. Yeah, we include seminal vesicle as well, but we are not very generous or very radical here. The intent is really palliative. 55 gray in 20 fraction, we just include CTV and seminal vesicle all within a one volume. There is no difference between prostate and seminal vesicle dose in this. Yeah, we don't include full seminal vesicle unless it is involved. We just include 2 centimeter as in a high risk population as a single volume. Could you elaborate on the way are those constrained in hypofractionated radiotherapy? Yeah, if you can Google chip trial, and it's pretty well available in the 60 gray 20 fraction, you can use the OIR constraints in that. And it is not just chip, there are so many hypofractionated publication came across board, and Europeans and the United Kingdom totally moved towards hypofractionation. And it is very well tolerable and very compliant. Patients really appreciate finishing the treatment within 20 days time without any break. You can send me a message. I can forward my protocol, whatever they are using. And within this slide, I have included the constraint for the hypofractionated RT, but I can't recollect by memory. I can share you. Right. Thank you so much to my institute, JIPMAL, and pretty much appreciable for coming with nice concept discussing the updated guidelines. This is really helpful even for me. I was just reading all the updates in the recent time. What you prefer, VMAT or multiple field? We use VMAT or double ARC or IMRT. Yeah, either way, whichever. VMAT is quite fast. You can finish the treatment quickly. But yeah, IMRT is equally good as well. As long as you are not using 3D CRT, that's fine.
Thank you, sir. I think we'll wait another couple of minutes for questions.
Yeah,
They're
yeah.
still coming in. So thank you so much for the comprehensive coverage of the minutiae of the management of prostate per se, in addition to the target volume delineation.
Right.
We loved your coverage of MRI as well as the use of exclusive CT as is available in most of the Indian institutes.
Yep.
So this is going to be an invaluable resource for our candidates, I think, who are attending.
Pleasure.
It feels
Yeah,
very
more than
refreshing.
happy to answer future questions. You can mail me. You can share my mail ID to the radiation oncology colleagues. You can ask questions. I can answer regarding the prostate cancer. Yeah.
Sure, sir. There's one more question, sir. Can you please tell about the IGRT protocol for hypofractionated RT?
Can you please tell about the IGRT protocol for hypofractionated RT? We use daily cone beam CT images if you are not using fiducials, but if you are using fiducials, you don't need to do daily cone beam. If you are using CyberKnife, again, you need to be very strict. Yeah, daily cone beam is definitely required for IGRT protocol. That's what we are following, and utilize cold fiducials if possible. And utilize MRI scan as well. You can nicely compare, or if your physicists are kind enough, they can even merge the MRI, which can guide for accurate radiotherapy. Okay.
Thank you so much, sir. So we'll keep collecting the questions. If anyone has any questions, they can message them on
Sure.
WhatsApp,
Keep
and
sending
we'll
keep
forward them
messaging.
to Tirugam sir. We can compile all the Q&As and conduct another panel discussion or a review session towards the end of the whole course. We'll try to answer as many questions as possible. So thank you so much, sir, for the